Good morning, ladies and gentlemen, and welcome to this panel on fighting back against global health setbacks, powered by the Bill and Melinda Gates Foundation and the Global Fund. Global population health progress has stagnated for nearly a decade, marked by entrenched inequalities in access to essential services, health risk exposure, usage of innovative tools, research capacity, but also responsiveness to crises like pandemics. Since 2015, the World Health Organization has observed a decline in the annual rate of reduction for indicators such as maternal mortality ratio, neonatal mortality rates, and premature mortality from major non-communicable diseases, while the Global Fund has reported a decline in key programmatic results for HIV, tuberculosis, and malaria in 2020, and that is the first time that this has happened in 20 years. In light of this, how can the global community empower low and middle income countries to achieve an effective recovery on their own terms, getting access to innovative tools, accelerating data collection and analysis, strengthening healthcare systems, moving beyond the siloed implementation strategies, and empowering grassroots organizations and neighborhood groups to spearhead global health improvements? My name is James Carty. I'm the Deputy Director for the Middle East at the Bill and Melinda Gates Foundation, and I'm joined by a distinguished panel to help answer these questions. Lady Rosalind Marauta, Global Chair of the Global Fund, who, after a distinguished career in public service in Papua New Guinea and as former First Lady of Papua New Guinea, has been working with the Global Fund for many, many years and is now the Board Chair. And Martin Edlund, who has a number of jobs, including CEO of Malaria No More US, the Executive Director of their Health Finance Coalition, and an Ambassador for the Global Fund's 7th Replenishment. His work with the Health Finance Coalition is particularly relevant to this discussion as it brings together donors, investors, and technical partners to develop new innovative financing mechanisms to mobilize private capital to achieve public health goals at a time of soaring demand for financing and more constrained public budgets. Welcome to the panel.
Thanks very much.
Sadly, Sami Assad from the Coalition for Epidemic and Preparedness Innovations is unable to join us due to family circumstances, and so we wish her well and her family well. And as a result of that, we've got a slightly smaller panel, so I may, as well as moderating, join a little bit in the discussion if you'll excuse me for that. Lady Rosalind, I wonder if I could start with you. The Global Fund has recently had a record-breaking replenishment round that generated more than $15 billion for the fund. Gavi raised $21.2 billion for their 21 to 2025 replenishment. Some might argue that there's never been so much money going into global health. However, we all know that the outlook for funding going forward is difficult, and there are voices arguing that a lack of efficiency in the global health architecture and a lack of coordination between different groups who are all doing similar things is making this more difficult. What can global health organizations do to improve coordination and make the best case for continued funding for health impact?
Thank you, James. Yes, it's true that the Global Fund raised $15.7 billion last year for the next 3 years at our replenishment conference in the US. And that money is to fight HIV, TB, and malaria in over 120 countries, including some regional grants, including in the Middle East. And this is, in fact, the largest funding ever received by a global health organization. I think the Gavi one includes all the COVAX money, so it's a little bit distorted in terms of their programming ongoing. But it was a remarkable achievement and reflects the generosity of our donors and the advocacy of people like Martin, who was an ambassador for the 7th replenishment and hopefully for the 8th as well. And it also reflects the impact that the Global Fund has had over the last 20 years. In the 20 years since we were founded, the partnership of the Global Fund has saved nearly 60 million lives. And I think that's recognized by donors, and that's why we are so successful in our replenishment campaign. But we actually wanted more than 15.7. Our investment case argued we needed $18 billion for the 3 years. And that investment case was written before the Ukraine war, before the impact of the Ukraine war on inflation in the world, and the fiscal crises in many countries that ensued last year. So 15.7 billion sounds a lot, but in fact it's not enough. So we can't be complacent. And at the same time, we have many new challenges. There's conflict all over the world, disasters from climate change, severe climate events which are affecting the three diseases, debt distress in many of the countries in which we work, and many countries still recovering from COVID-19. So this is increasing the challenges that all the countries we work in are facing and not helping their efforts to build resilient health systems. So it's in this context of tight resources and increased challenges that we now face. So how are we responding? We're continuing to make the case for continued funding for health impact, both from donors to fund grants, all of our money is grant money, and domestically from the countries where we work, for them to also attempt to increase their health expenditure. We're pushing hard for cost savings, more health for the same money. And through our pooled procurement, we've secured lower prices for many commodities. Just 2 months ago, we announced a reduction in the price of antiretroviral drugs, first-line drugs, by over 20%, 25%, thanks to the generic companies in India, which agreed to reduce. So now, ARV treatment per patient per year is down to $45, which if you compare with 20 years ago is really an astonishing record. We've also managed to reduce the cost of cartridges for gene expert machines for TB diagnosis by 20% in the last 2 months. And just recently we announced a 55% reduction in the cost of bedaquiline, which is one of the drugs used for multi-drug resistant TB. 55% reduction, which is quite extraordinary. So with the money we have, we're able to do more through these price decreases. And we would like to introduce new dual action nets for malaria, much more widely than we've been able to in the past. They work more effectively than the existing nets, but they've in the past cost quite a lot more. We've now got a price reduction in those nets, so they're only 70 cents more than the traditional nets. So that will also help the fight against malaria in many countries. And we're also intensifying collaboration and coordination with other health agencies like Gavi, which you mentioned. Gavi works in around 60 countries. We work in over 120. There are 50 countries in which we both work, or just over 50. But we have quite different mandates. Theirs is to make sure that countries have access to vaccines. Ours is to make sure that we target HIV, TB, and malaria prevention and treatment. But we worked together very closely during COVID. We were both very active in the Access to COVID-19 Tools Accelerator, where, as we all know, Gavi helped to accelerate the development and then the distribution of COVID-19 vaccines. Global Fund didn't work in the vaccine space. We were the primary funder for all the non-vaccine elements of COVID responses and provided grant money for countries immediately to fund tests, treatments, including medical oxygen, PPE, and other critical elements of health system strengthening, particularly with laboratories. So our collaboration during COVID, but it had started before that, showed us the importance of working together closely, and we're taking that further now, particularly in relation to health system strengthening work that we're both doing. So as we navigate this very complex global landscape, I think it's really important that organizations persistently champion collaboration and coordination. We need to optimize investments for impact and continue to make the compelling case for funding, because every dollar is just not an investment, but a commitment to a healthier, more equitable life for everybody.
Thank you, Lady Ross. And you've told a very compelling story about both the efforts that you're making in terms of cost savings, negotiation to lower the cost even of innovative products, and obviously the importance of collaboration. But you do also point out how tough it is out there in terms of raising resources. And Martin, I'd like to turn to you now. We are at a time of almost unprecedented innovation in healthcare. For example, in malaria, as you well know, we're on the cusp of a number of promising innovations in terms of vaccines, bed nets, treatments, data tools, etc. But innovation is expensive, and donor government finances are stretched. We've heard that very clearly from Lady Ross. The war in Ukraine, the inflation that has caused, etc. And resources are very likely to be scarcer in the future, just as we have these pipelines of expensive, innovative products coming down the pipe. How can we finance innovation and the scaling of that innovation without being able to raise significantly more money?
You laughing at my
We shouldn't laugh, but
You should say
Can everyone
impossible.
hear us okay, first of all? Okay, great. Yeah, I mean, we do face, as you point out, almost a perfect storm of challenges. In the malaria effort, we're facing drug and insecticide resistance, which is, of course, a response to the success we've had. We've gotten 3 billion mosquito nets out there, but now the mosquitoes are responding and they're resistant to the insecticides that are being used. The same thing is happening with our frontline treatments. We're seeing drug resistance. Part of the perfect storm is actual storms. Climate change is making these challenges harder. It's causing the mosquito to go to new latitudes and new altitudes where we didn't see them before. I don't know if there are any other Americans here, but for the first time this year in 20 years, we actually had local transmission of malaria in the United States. COVID, of course, was a big setback as well, both because of the financial constraints, the costs it imposed, the kind of debt distress to countries, and because it disrupted health services. One of the things we were really afraid about at the outset of COVID was that we'd see what happened with Ebola. During Ebola in West Africa, you actually had more people die of incremental malaria cases because they stopped testing and treating than you had people die of actual Ebola in the 3 most affected countries. So there were real concerns that would happen as well. To actually get to your question about fiscal constraints,
Where's the money
I'm done
coming?
stalling. Anytime that you're trying to kind of balance a budget, you've got the 2 sides of the ledger, right? You've got your costs and then you've got your revenues. And we've really got to think creatively about both sides of that equation. On the cost side, we've actually benefited for the last 20 years in kind of growing scale and falling costs for the core commodities. When I started, when Malaria No More launched, bed nets cost about $7.50 per bed net. They're down, standard nets are down to under $3 a net. So resources have been growing, and what we can buy with those resources has been growing for 20 years. But now that equation's flipping. Now we need these dual active ingredient nets, and they cost, as Lady Ross pointed out, about 70 cents more per net. So all of a sudden, we can cover fewer people with the same money for the first time in about 20 years. So on the cost side of the equation, we've got to get a lot smarter about how we target resources. Data has been pretty poor over the course of this fight to date. It's getting much better now, so we can do subnational targeting. In a place like Senegal, where I lived for a couple of years, you actually don't need universal net coverage everywhere. There are places like San Luis where malaria is kind of very sort of scarce, highly seasonal. It's not something that people need to be sleeping under nets all year round. Then you have places like Kédougou where they really do need that all year round. So we need subnational targeting. We need to use the resources we have as efficiently as possible to create the biggest health outcomes. But ultimately, we need to think about the revenue side of the equation as well. There a lot of hard work and a lot of generous support went into the Global Fund replenishment. It was bigger than in the past, but it wasn't everything that was needed. So for malaria, that means we have about $1 billion gap over the next 3 years just to maintain levels of coverage for testing, treatment, and nets. And so we've got to think creatively about how we do this. One of the things that we've been doing as Malaria No More is really thinking about a new model of financing. One that it uses grant capital to crowd in private investment to achieve public health goals. So we've created something called the Health Finance Coalition. Grateful to both the Gates Foundation and the Global Fund for being on our steering group, along with the World Bank, the WHO, Rockefeller and Skoll Foundations, USAID. So we got all those funders together and we said, let's try to demonstrate some new models for how we bring private investment into these kinds of needs and efforts. We've been at it for 3.5, 4 years. We've mobilized about $300 million in new funding for these initiatives. One structure that relates directly to malaria was something called the Regional Malaria Elimination Initiative, RMEI. I almost forgot my acronym. RMEI, which targeted 5 countries in Central America and the Caribbean. And what we did was work with the Inter-American Development Bank to make concessional loans available to countries. And then we brought in some catalytic grant capital from the Global Fund, from the Gates Foundation, from the Carlos Slim Foundation, both to fill some capacity gaps and to create some outcome payments and incentives to countries who used this money well and achieved great outcomes. I'm excited to report that 2 of the 5 countries that we invested in 4 years ago through the RMEI have since eliminated malaria. So we're seeing great progress toward that goal in that example. And we have a bit of time left. Happy to talk about other examples. Just to preview one, we've just launched a new fund investing in scaling private sector health enterprises that serve the needs of the most vulnerable in sub-Saharan Africa. So we call that the Transform Health Fund. We've raised 70 million of the target $100 million. That's a joint venture with one of the top investment firms in Africa, a group called AfriCinvest. And there's some creative but slightly nerdy things about it, which we are happy to talk about. One is we brought grant capital and commercial investment in. We've blended those in the fund to lower the cost of capital for the companies. So we're able to invest in those truly high impact businesses that are trying to scale to peri-urban, rural areas to really meet the needs of the most vulnerable across the continent.
Thanks, Martin. And interesting you should bring up that question of innovative blended finance. We have a fund in the Middle East housed at the Islamic Development Bank called the Lives and Livelihoods Fund, which is funded both by Saudi Arabia, Qatar, the United Arab Emirates, and the Gates Foundation, as well as the Islamic Development Bank, which does exactly that blended capital. So it combines grant financing from the donors with capital from the Islamic Development Bank to make it much cheaper for countries investing in the social sector, particularly in healthcare, also in agriculture and in small-scale infrastructure for social things such as water, sanitation and hygiene, and enables them to be able to more easily finance things that wouldn't necessarily be a priority for them otherwise. And again, has had a huge impact. I mean, we've done a lot of work in Senegal on malaria with that fund. We've done a lot of work on neonatal, maternal and newborn child health as well, particularly in sub-Saharan Africa, but across the Islamic world as well, all the members of the Islamic Development Bank. So it's really good to see more of those approaches coming forward and opening up that stack of capital that can be used to address these global health challenges.
Can I just jump in with a quick comment there? So the Lives and Livelihood Fund is a great example of something that wasn't happening even a few years ago, which is the aid agencies speaking with the investment banks and the multilateral development banks. We've been delighted, but a little surprised, that 2 of the structures we created were the first times that the 2 parts of the US government, USAID, which provides grants, and the US Development Finance Corporation, which provides equity investments and loans, it's the first time that they've invested together. So we're starting to see more and more examples like that of leverage across grant capital to investment. We often talk about how you stretch grant investment, but I think we actually need to be in a mindset of multiplying grant investment by unlocking more commercial forms of investment through structures like the Lives and Livelihoods Fund.
Thanks, Mark.
James, can I just make a comment on this topic too? I think it's really important that we put a lot of effort into these new blended innovative financing, but we shouldn't pretend that they're easy. They take a long time to negotiate. There are often many conditionalities that are set that organizations like the Global Fund that has very strict rules for accountability of money and so on, have to circumnavigate. So they're not easy to negotiate, but we've been able to successfully use grant finance to catalyze World Bank money in a number of countries. We've done that in India for a very big TB grant, where 40 million Global Fund money then got a 400 million grant from the loan from the World Bank. Similarly, in Indonesia, we gave 30 million as seed capital for a 300 million loan for Indonesia on very concessional terms. But the private capital is also important, how we can use these funds to secure cheaper financing for countries. But we shouldn't think that this is the answer to financing health in the future. Most of the countries that the Global Fund works in cannot afford to increase their domestic expenditure on health, whether it's through debt finance or just straight from the budget. And we can't lose sight of that. And I sometimes worry that these new forms of innovative financing are being used by donors as an excuse to reduce ODA. So we really have to be careful that we still make the case strongly for high levels of ODA from richer countries for poorer countries.
I think that is a very good point, and it's certainly one that we would be very, very strongly of the same opinion. I guess in an era of shortage, you have to look behind the sofa cushions for everything that you can get.
Exactly.
And this is another tool in the arsenal, but it should not be seen as a replacement for ODA and that long-term, stable, large amounts of funding that will support the poorest countries.
It's a way to increase the money available, not supplement what's already there.
Money is obviously a big part of the equation. I did originally have this question for Samia, but unfortunately she's not here, so I hope that we can, between us, address it, because I think it's an important one. Despite the best efforts of the Global Fund, CEPI, Gavi, and others, the pandemic really laid bare the inequalities in global health, and not just in terms of financing, but also in terms of access in particular. We saw that with vaccine access. What do you think can be done to address those inequalities in access and in delivery, not only in times of pandemic, but also under normal circumstances? And I don't know maybe I'll start with Martin or Lady Russ.
Yeah, I think that's absolutely right. COVID laid bare the inequities that have always been there. And the problems with supply chain and procurement and delivery of commodities during COVID were absolutely apparent. But it wasn't just the delays in getting access, it was also the cost of the commodities and the inability of many countries to actually get them, afford them and get them. And since COVID, there's been a very big push for regional manufacturing of health commodities. Obviously, you can't have plants in every single country. That would be crazy. But on a regional basis, I think we do have to look at that, keeping in mind the need for cost effectiveness at the same time and the economies of scale. We can't just willy-nilly start manufacturing everywhere because it's closer to the source. But we have to take that into account. And there's a lot of work now being done on regional manufacturing within Africa, for example, where 70% of Global Fund money is based on the burden of disease and the ability of countries to pay. You know how our allocation methodology works. It's not even across all the countries who apply. It's based on an analysis of the burden of each of the diseases in the country and the ability of the country to pay for its own health programs. But yes, but that's not the only sort of inequity, is access to commodities. There are many other inequities which we face all the time, particularly with malaria too, but particularly with HIV and TB, where you have all the problems of stigma and discrimination and problem of vulnerable communities where infection rates can be very high, being able to access health services for a number of reasons. So it's within country that there are huge inequities as well as between countries.
A very good point. And I think, Martin, you had some interesting statistics about just in terms of the inequality of access.
I did, so I'll refer to my notes quickly. I was struck by these. Sub-Saharan Africa accounts for about 14% of the global population, 20% of the global disease burden, yet it only has 3% of the world's health workforce and receives less than 1% of total global health spending. So just huge disparities between kind of an outsized burden and really a kind of anemic access to both the capacity and the resources. But something your question made me think of is, another inequity that I think will be bigger and longer term than COVID, and that's the inequities in the climate crisis. Increasingly, the world is waking up to the fact that the climate crisis is also a health crisis. If you look at something like the apocalyptic historic flooding in Pakistan that happened last year where 30% of the landmass was underwater, all the cameras were trained on Pakistan for that kinetic event. You saw these towns become inland islands due to the flooding. But there was much less attention paid to what happened 2 and 3 and 4 months later when you had a 350% increase in malaria and dengue cases, massive outbreaks of cholera, a 2 and 3-fold increase in the health burden on hospitals that were trying to dig out from this crisis. And so if you take examples like that and you pop it up to the global level, what we're facing, let's be honest, is an environment where the climate crisis, which was not created by these frontline countries in places like sub-Saharan Africa, but they're now bearing the brunt of this. And so, it's exciting to see that for the first year this year at COP28, there'll be a health day, so focused on the health impacts of climate change. But when you look at global spending on climate, only about 0.5% of overall climate spending is spent on health at the moment. We've celebrated over the last several decades the fact that global extreme poverty rates have been falling at a historic rate. But we're at risk of that reversing. So the World Bank did a study where they estimated that by 2030 we could see as many as 132 million people driven into extreme poverty by the direct impacts of climate change. And when they actually dug into the numbers and looked at the drivers, it was climate's impact on health that was the single biggest driver. Fully a third, 44 million of those people driven into extreme poverty, it could be because of climate's impact on health through the kinds of diseases and causes that we're talking about. So we've got a long way to go, not only to kind of fill the coffers on the health side, but also to get the climate community to think seriously about adaptation spending and prioritizing the communities that did the least to cause the climate crisis, but are unfortunately bearing the brunt of it.
I think that's a very good point, Martin. I think that the climate conversation, the impact of climate change on health, I think will only grow. I think, as you said, this year is the first time that will be addressed at COP, but I think it will become a much bigger part of the conversation. It would be quite remiss of me if I didn't channel my inner Samir at this point and talk a little bit about the sorts of things that the Foundation and CEPI are doing in terms of access. I think in every
grant... Do you want us to ask you the question so you feel like...
Please do, yes.
James, could you tell us about the Gates Foundation's priorities and what you're doing to respond?
I mean, I think in terms of the access to tools and innovations, as we've discussed, innovation is expensive, it doesn't come cheap. So in the grants that we write, in the grants that CEPI writes, we always have access clauses in those grants to ensure that there is an element of these products that we're helping develop that ensures that they are made available to low and middle income countries. I think, as you pointed out, Lily Ross, distributed manufacturing is a complex question. It would be lovely if we could put vaccine manufacturing plants in every country in the world, but there just isn't the demand for those to be kept busy and to have the economies of scale that they need to be able to get the most amount of vaccine for the least amount of money. But one of the things that we are investing in as the foundation is innovative tools that enable you to have much smaller footprint manufacturing facilities that are able to manufacture at quite large scale that can be deployed to appropriate areas, and that's obviously something that will be coming in the coming years. But those sorts of innovations that enable lower cost, easier, smaller footprint, and easier to use facilities that will enable that sort of access. So I think that's one to look out for, certainly. I also wanted to come back to this question of communities. And the communities of those living with and most affected by epidemics are often at the heart of the response. And how can we continue to get better at engaging with communities and improving the overall health outcomes? And how can we evolve our approaches? And maybe, Lady Rosemary, I'll start with you again and we'll come on to Martin afterwards as well.
I have the privilege of being female in this, in this circumstance. Communities are at the heart of the Global Fund and the way we work. They always have been. We have a very interesting and unique structure at the Global Fund in terms of governance, where there are 20 voting seats on the board, 10 of which are occupied by donors and 10 by recipients of the grant funds. And 3 of those seats are for civil societies, one of which is for communities, for people who are living with HIV, TB, and malaria. And it's very clear to us, and I think COVID made it also clearer to the world how important community health responses are. The countries that responded better to COVID were ones where they used community health workers best. Vulnerable people are most at risk from the diseases that we are trying to eliminate. And they're often hugely marginalized by poverty, by stigma, discrimination, or in some cases, criminalization of the activities that they're involved in. And we try to reach those people as much as we can, because they are, in fact, the drivers of both HIV and TB. TB is a disease of poverty, nothing else. So unless we tackle the root causes of overcrowding in housing, of people not being able to afford food so that they can take TB drugs, we'll never overcome TB. So much of Global Fund's investments are tailored to use community organizations. We don't just work through government, where we fund many community organizations in all the countries where we work, particularly for health prevention, but also for treatment. We're supporting community-led monitoring of our grants to make sure that the people we are supposed to be accessing are accessing those services. And we've seen where we've introduced community-led monitoring in the last phase of grants that has really helped access by marginalized people. One of the areas where we're also working is in a number of countries is how to build community health workers, integrate them into the national response. And where we've assisted countries to do that, there's been great success, like Ethiopia and Rwanda, and I think they're both models that many other countries should follow, where they've had huge improvements in health outcomes as a result of the community health programs. So the current strategy of the Global Fund, which is from 23 to 28, explicitly put communities at the center of all that we do. It's not easy when you're used to just delivering services through government to make sure that communities are involved. It works better in some countries than others. Different governments are more receptive to community health than others, but it's clear that you have the best success when communities are involved.
Thank you, Lady Ross. Martin, would you like to comment?
Yeah, maybe just an example. You know, I think community health workers are vitally important. I think the Global Fund is almost unique as a global financing organization that's so deeply embedded and invested with communities. But one of the other things that comes from communities is innovations. And it happens in ways that you can't anticipate. That's the power and the beauty of these community-led innovations. An example from my time living in Senegal, there was a tragic story of a father, El Hadj Diouf, who lost his 9-year-old daughter to malaria. It was a hot season. They weren't sleeping under their bed nets. And malaria is especially pernicious because you can die within 24 hours of the onset of symptoms. And so this happened to this father and his daughter. He vowed when that happened not to let there be another single death from malaria in his home community. And so he organized the community, and they actually had a brigade, you could call them community health workers. They would go out at dusk each night and they'd ring bells. And the bell meant it's time to get your kids sleeping under their bed nets.
Yeah.
And so that spread from his village to dozens of surrounding villages, covering tens of thousands of people. And over a space of the next 3 to 4 years, there were no deaths from malaria, not only in his village, but in that surrounding area. And so examples like that should inspire us, but they should also inform us about the kinds of techniques and approaches we should take to addressing these problems.
Thank you, Matt. I think that's a really wonderful example, and this idea that we tend to sort of think of innovation as being something that happens in laboratories and with men and women in white coats, but I think that point that innovation is not just about new drugs, it's also about the different ways of doing things, and that the community is at the heart of that. The people with the actual real lived experience are often the best innovators. I think that was really, really powerful story, and wonderful to hear the way that communities are involved, both with the Global Fund and elsewhere. I do want to make sure that our audience has a chance to ask some questions as well. So would anyone have a question for the panel? Any questions from the audience? Yes, we've got one here. Do we have a mic?
Yeah.
Yeah, I think that's great. And so genomic sequencing of individuals rather than of diseases, are we working on that? I don't know, Lady Ross, if you'd like to comment on that one?
It's not an area I'm totally familiar with, but I know that, again, as a result of COVID, we've seen how gene expert machines can be used for such a huge number and genomic sequencing for so many multiple uses. It's not just for diagnosing COVID or TB, but can be used for all sorts of things, for cancer and so on. Genomic sequencing also through water treatment analysis and so on, not just for COVID, but for all kinds of disease. So yes, it's something that Indonesia actually is really taking forward in a big way. And we're having quite a lot of discussions with them as to how we can support that.
Martin, have you had any?
Just quick addition, and it's not exactly what you're asking, but I started my comments saying we need to better target the resources and the tools that we have. In the malaria campaign, there's a lot of work to do genomic sequencing on both the mosquito and the parasite.
Yeah.
So you can really see kind of how they're traveling. Oftentimes it's human populations moving from place to place that bring the parasite to those areas. So genomic sequencing is really vital for that. It's also helped us to see, for instance, that there's a new mosquito vector. It's called Anopheles stevensii that came in through Djibouti and has spread across Central Africa all the way to Nigeria now, and is bringing malaria to urban areas. So it's helping us to see those problems early and start to adapt our strategies.
And the point about that mosquito is that it's coming to areas where previously there was no malaria, and yet the infection rates from that particular type of malaria are huge.
Around the September time. So in Milan, the mosquitoes would disappear around September, but now they believe that they have a strain that's from Korea because they're surviving the winters even in Milan, and so you get bitten almost all year. So my name is Caroline, and I work at Google, and so I would love to catch up to actually find out more of how we can also help you with some of this work.
Yeah, that would be great. And just to your point about kind of the changing rainy seasons and the new vectors are really kind of changing the dynamics. In places where mosquito-borne disease used to be highly seasonal, 2 or 3 months, it's now often 4, 5, 6 months, or sometimes present year-round as a result of these changes.
It's not just changing rain patterns, but also heat. In Papua New Guinea, where I live, in the highlands, we historically never had malaria, but there's quite a lot of malaria, particularly in the lower highlands now, because it's so much warmer and the mosquitoes are traveling up the highways.
Thank you both. I think we have time for, if there's one more question, otherwise I've got plenty of other questions that I can ask, but any other questions from the audience?
I think we're
Don't be shy. Well, maybe I will. I think we've got a few more minutes to go, but maybe I can finish with my last question. I mean, we've had a slightly depressing view of the changing climate and the impact that that's having on disease. We've talked about the tough financing situation and the expense of innovation, etc. The framing of the whole panel was about stalling progress and doom and gloom. But I'd like to end on a more hopeful note. So I'd love to hear from you both. What gives you hope for the coming years that progress can be reignited and further progress made? And perhaps we'll start with Martin this time, and then we'll move on to Lady Rose.
If you don't mind.
I don't mind.
I mean, frankly, lots gives me hope. We talk about malaria as a challenge of scope and hope. The scope of the problem is massive, but we actually have a pipeline of tools that's more powerful and gives us greater hope that we can eliminate and ultimately eradicate this disease than ever before. You know, a lot of them invested by the Gates Foundation, by the US government and other partners. Just thinking about kind of this setting of FII and our hosts in the Kingdom of Saudi Arabia, I think there's also a really exciting role for Saudi Arabia in this region to play. Listening to the panels and discussions over this week, it's clear that Saudi Arabia is at the nexus of some really important trends. Number one, it can be a bridge between East and West, North and South. It's certainly a gateway to Africa. Secondly, we talk about blended finance. I think Saudi Arabia can be at the nexus of public and private finance to solve these problems. And then it's also at the nexus of climate and health. You know, we heard from some other partners about extreme heat, about the risk of dengue fever here in the Kingdom of Saudi Arabia. How can the lessons and the innovations you're using to solve those challenges here benefit other communities around the world? So I think there's a growing role for Saudi Arabia and the region to play in solving these global problems.
Thank you, man. I think we maybe very, very quickly, Lady Ross, because I realised my watch was a little bit slow, so very, very quick reasons for hope.
What gives me hope, why do I keep on doing what I do, is the very success we've had. Since the Global Fund was created, we've reduced deaths from HIV, TB, and malaria by 55%. So, I mean, we can't really imagine a world where that hadn't happened. And we know, as Martin said, we know what works. We've got the tools that work. We just have to apply them more and more efficiently. So that's what gives me hope. We know how to defeat these diseases. We just need to get on and do it.
And on that hopeful note, Martin, Lady Ross, thank you so much. Thank you to the audience as well. Thank you.
Thank you, James.